How important is it also to discuss these sarcomas with your colleagues at your institutions?
Yeah, I think it's critical. This is a multidisciplinary disease. So every new patient at Sylvester is discussed at our multidisciplinary tumor board, where we have not only a medical oncologist like us, we have our pathologists, radiologists, we have our surgeons there, and everybody can even at times help make the diagnosis. You know, we've all run into these extraskeletal osteosarcomas and these entities that you really have to understand. The pathologist and the radiologist have to get together to really make the diagnosis. So I think it's really key. I'd be interested to hear what the others on the panel say about multidisciplinary conferences.
I would just add, it's not only critical to talk about with your colleagues at your own institution, but also elsewhere. So, you know, even for their specific histology, you know, being at a sarcoma center, we're all at sarcoma centers, there are a few cases a year of something I've still never seen. And so reaching out to, you know, each of you and others of our colleagues to sort of get their impression and experience, I think is important. To John's point, we also have a multidisciplinary board with orthopedic oncologists, radiologists, pathologists, peds, hem-onc, med-onc, rad-onc. Because it's critical to sort of do this right the first chance we can.
And it can be complicated. I mean, so at Denver we have also a multidisc clinic where but getting all the surgeons in the right place together is also complicated as well. You need to have your orthopedic oncologist, your thoracic surgeons, your GI surgical oncologists, you know, plastic surgeons involved. And so it's actually quite a big team. And the more people you have in the room, you have hundreds of years experience in the room that have seen these tumors, and really it makes the care optimal for these patients. And so I think seeing a sarcoma center is so incredibly important, that it's not just one person that you're seeing that has expertise, you're really seeing a whole team that really can help optimize care.
Yeah, I think that's one of the important messages that we can get out to our community oncology colleagues. You know, we're really there to work with them, but that initial diagnosis and the initial management of the patient is critical, even from approaching the initial biopsy, because sometimes you have to consider the biopsy within the resection that will be planned. And so this multidisciplinary approach is critical. So what do you think about when you first see a sarcoma patient? How do you approach that? How do you put into context what this patient will go through, and what are some of the things that you think about when you're going to approach the patient to start with?
First, is it curable? And how do we get to that point?
What does curable mean to you, and what are the patients that are curable? What are the ones that are a little bit more challenging to cure?
So I think a big question is resectability. Most things are potentially resectable, but you're always trying to balance off quality of life and morbidity, meaning toxicity of a resection. Right? You can always take off a leg, but you don't want to do that. So limb salvage is incredibly important, and that involves multiple layers of care, radiation therapy, a good surgeon that knows how to actually do these surgeries appropriately to maximize outcomes and optimize ability to actually use the limb. And also consideration of chemotherapies or systemic therapies to really improve overall outcomes. And so I think that and it's nuanced. And so staging criteria in sarcoma are not that helpful, frankly. I mean, because it's almost like saying you have a single staging criteria for all carcinomas. You can't apply everything to that particular criteria. So we use very, very gross, well, stage 3 is a large 5-centimeter tumor that's high grade, and that's kind of a baseline, but it requires a lot more nuance than that. Yeah.
I think one of the important things is the sequencing of chemotherapy, radiation, and surgery. So that's where the tumor board comes in. Should we do chemotherapy first before surgery? Should we do radiation and chemotherapy? Or should we go ahead with surgery and then do adjuvant chemotherapy? I think that's really important. That's what the sarcoma tumor board allows us to do with all the players in the room.